Hello, and welcome to PACE's first ever webinar. Hello viewers, I'm joined today by some panellists who I'm going to introduce to you now. On my left, I have Nuno Nodin, who's PACE's Research Manager, and then next to Nuno, I have Gemma Lunnett, who's our Mental Health Advocate. And on my right, I've got Jess McIntyre, who's our Professional Practice Trainer. And then to the right of Jess, Sola Barbosa, who's our Counselling Manager. PACE is the LGBT+ mental health organisation. We've been working for about 30 years with the LGBT community to improve their mental health. We provide counselling and advocacy. We do work with young people, and increasingly a lot of our work is online because that's what our clients increasingly want. We also have research at the heart of the organisation, and this webinar comes out of some research that we did, which you're going to hear about later. So that's an introduction to the panellists. I want to just talk a bit about the goals of the webinar. This is the first of a two-part series of webinars. The second will be broadcast on the 3rd of November, also from 2 to 3 o'clock in the afternoon. This first webinar is called What We Know About the Experiences of LGBT+ People in Organisations. Drawing on PACE's experience over 30 years in dealing with the mental health care and wellbeing needs of LGBT+ people, this first webinar will focus on the experiences that LGBT+ people have, particularly within mental health and social care services, where organisations commonly fail to meet the needs of LGBT&T people, and how this can negatively impact on the care-seeking behaviours and the recovery processes of LGBT people. So do remember to register for the second webinar. It will have new guests who will provide suggestions on how to address some of the issues being discussed in this first webinar, based on the experience of their organisation. So what I'm going to do now is just cover off a bit of housekeeping. This webinar is broadcast live, but will also be made available later on our website. And viewers can comment during the webinar via Twitter using #PaceWebinar and sending questions if you'd like to via the facility provided by the webinar software. Before the end of the session, selected questions and comments will be addressed to the panel that come in from viewers. So the first question, which I'm going to now offer to the panel, is why is it relevant to improve LGBT people's experiences in organisations? We're going to start with a recap of the research, the findings from the RARE research, which link with this issue. So I'm going to hand over to Nuno. Nuno, can you tell us about the study and how it might help illuminate this discussion?
Yes, of course, Margaret. So I'll start exactly by providing a bit of background about the RARE study, and some people might be familiar with it. Basically, it's a multi-phased research project that started in 2010 and will be ending at the end of this year, 2015. It has been funded by the big lottery, and it's led by PACE. And there's a few core issues that we're looking into with this project. So basically, we try to understand why LGBT people suffer from more mental health issues than heterosexual and cisgender people. And we did that by specifically looking into three particular topics or issues that LGBT people experience disproportionately. So we looked into raising resilience factors for suicide among LGBT young people. We also looked into drinking problems among lesbian and bisexual women. And finally, we looked into body image disorders and eating concerns among gay and bisexual men. So these were the three key topics that we looked into more specifically. And the project was also led in partnership with 3 academics from 3 different universities. So with Ian Rivers from Brunel University, with Elizabeth Field from University of Worcester, and also with Al Talib from South Bank University. So I'll briefly outline the phases of the research that we carried out. We had 3 data collection phases, 2 of which were qualitative, so basically phases in which we interviewed people about their experiences with mental health and resilience as well. And we carried out a large survey in 2013, which collected data from over 2,000 participants from all over England, including heterosexual participants, where we compare their results with those of LGBT people, and also cisgender, comparing with heterosexual people. So basically, I'm going to share with you some of the findings from the first phase of the research. So this was the phase in which we interviewed people who experienced the mental health issues that I mentioned before. And I'm going to be focusing specifically on findings that link directly with the topic of this webinar, as Margaret mentioned. So I'll start off with sharing some of the key findings regarding suicide and self-harm for young LGBT people. And what we heard from the narratives of the group of people I've interviewed, that as young attempted suicide, mostly related with incidents about their sexual orientation. So what we found was experiences of a lack of awareness and training, which meant that responses from medical and professional staff often felt inadequate to participants. We also found that inclusive resources, which reflect the lives and issues of young LGBT people, are sparse outside of LGBT plus specialist services. And finally, we also found that positive interventions and responses from medical and professional staff are crucial to help young LGBT people recover more quickly after a suicide attempt. So moving on to the findings regarding alcohol misuse for lesbian and bisexual women, we found a similar picture. So again, we found that negative reactions from professionals often affected this woman's engagement with treatment and support, which in turn, in many cases, led them to disengage with treatment altogether, often, obviously with negative consequences to their health. We also found on the other side that interaction with practitioners who were knowledgeable and were aware and inclusive in their approach was a key to recovery. And the same thing was true for finding LGBT-specific support, such as specific LGBT support groups, for instance, in relation to things like drug use and alcohol use as well. I'll be sharing a little bit more about that in a few minutes. Finally, in regard to the body image issues for gay and bisexual men, when we look into the findings of that specific subgroup of people we interviewed, what we found was that homotherapy and self-help, as well as organized programs, including those specifically targeted for gay and bisexual men, were considered to be important parts of the process of recovery. So when looking at these findings altogether, and specifically focusing on, if we want to subgroup them into risk and resilience factors in relation to experiences of mental health and social support systems, we can find that many participants found that help was not easy to find, and often they had to overcome barriers that they found their way. And these were mostly 2 types. One of them was there were emotional type, for instance, concerns around the potential reactions of professionals to disclosing their sexual orientation, but also practical, for example, lack of appropriate reactions to issues specific to sexual minorities, or the sheer lack of LGBT support. Looking at conversely, if we look at the other side, so how processes of recovery and resilience were affected by their experiences with professionals. So we found that participants discussed how positive experiences with sensitive and inclusive professionals were an important part of their recovery. So they were a key factor in that process. And others emphasized the relevance of LGBT-specific groups and supports as havens where they felt safer and where their issues were understood. To finalize my presentation, I'm just going to share with you a couple of quotes from participants that link directly with this specific these experiences in general. So the first one is from Isabel, who's a lesbian woman, 45 years of age. So Isabel said, I went to my GP and said I was really, really miserable. I actually told her she was one of the first people that I told that I was a lesbian, which was a bit hard for me, and she suggested I see a psychiatrist. So she put me in touch with the community mental health team, and they at the time diagnosed me as having a borderline personality disorder, which I don't really think I have. I think at the time I was very confused about my sexuality, and that is something that was never really addressed in those early days. So I'll share with you another quote from another lesbian participant, Simone, age 36. And Simone said, it was really important to go to a lesbian and gay AA meeting because I realized I carried some shame about my own sexuality, internalized homophobia. I needed to be with other gay people before I mentioned relationships or mentioned a girlfriend in a straight or mainstream meeting of Alcoholics Anonymous. It took me a couple of years to get to the point where I could mention my girlfriend and not give a shit. So these two quotes basically illustrate kind of almost extreme ends of the experience of dealing with professionals in healthcare settings and how these affect positively or negatively the experiences of LGBT people when accessing these services. So I'll leave it at that for now. I'm just going to mention the fact that these findings are just a few from many more that you can find in the research report that was published early this year and launched in March. And you can find it, you can download it from our website at pacehealth.org.uk, so make sure to look for it and to read the report if you're interested in finding a bit more about the research.
Thank you, Nuno. I think that was a really good summary of what is, as you said, a long report and a 5-year study, which PACE is very proud of and which we think adds significantly to the body of knowledge in the field. What I'd like to do now is broaden this out a bit and talk about some of the services, some of the issues that clients have in focusing in accessing services. Gemma, I thought it would be good to come to you in your advocacy role. You've been working with many clients experiencing mental health issues, helping them to navigate the health and social care systems, which I know can be very complex to clients. How does your experience fit with what we just heard? Could you maybe give us an example of some experiences that clients have had with things like discrimination or lack of awareness that have actually made things worse for them?
Yeah, sure. Well, absolutely. I've got many examples, but I picked out a couple that really stood out for me. I had a client who identified as a trans man, and he was admitted to A&E following a suicide attempt. He was assessed by a psychiatrist, but once he disclosed himself as trans, he was actually left for quite a prolonged period waiting whilst the site discussed with his colleagues, went back and forth a lot about whether to put him on a male or female ward. Obviously the client's mental health was already fragile enough, but the psychiatrist's actions actually brought him to feel a lot worse, had lots of further anxiety on top of that. Intrusive thoughts about not fitting into regular society, and that he actually causes more problems just by being himself. And another common issue that for women who have same-sex relationships is that when going through things like cervical screening or sexual health appointments, it's that the inevitable question of are you sexually active will always come up. And then from there it'll be what birth control do you use or do you use birth control? If you say no or none, then there's that automatic assumption that you could be pregnant and why don't you do a test and kind of get forced into coming out. Obviously bits like it can be quite a challenge for people who are mentally well anyway, but for somebody who's actually really struggling, I think this could make them avoid going to future appointments that could actually be quite fundamental and detrimental to their health. Similarly, actually, with some of my clients who are HIV positive, they have avoided seeking treatment for problems separate to their HIV, for example, going to A&E because they feel quite stigmatised once they disclose their status. And again, this could be detrimental to their health in general.
Thanks, Gemma. That's some really good examples. What might be useful now is for us to talk a little bit about professionals. PACE works with professionals to try to influence their behaviour and their understanding about LGBT people. And Jess, this is where you come in, isn't it? As a trainer for PACE, you've been working with groups of professionals within mainstream organisations on LGBT awareness. What sorts of questions do trainees ask you, and what do these questions tell you about the challenges that LGBT people face when accessing services?
Well, the main aim of the training that we provide for mainstream services is to boost the confidence of those services in working with LGBT people, and thereby boost the confidence of LGBT people in accessing mainstream services. Lack of confidence, I think, actually is the single biggest issue that I deal with in terms of the practitioners that I work with. Normally, this kind of manifests in language, lack of confidence around language, and misunderstanding around language as well. So, very common question, what's the difference between transsexual, transgender? Is queer an offensive word? Can we use it? The concern here is that a lack of confidence from the point of view of the practitioner actually leads to the client feeling like they need to go into, for example, a therapy room and do a sort of LGBT plus 101 with the therapist before they can actually get stuck into the real work of why they're there. You know, and this is on the client's time and money as well. So that can be a huge barrier. And actually, in my experience, one of the main reasons why LGBT people might choose to stay in LGBT-specific services, like come to PACE for counselling, rather than going to a mainstream provider. The other thing that is sort of broadly covers a training concern are heteronormative and gender normative assumptions. So this comes up consistently because society's assumption that people are heterosexual and cisgender, unless otherwise specified, the onus is placed on the LGBT person to come out rather than on the service provider to enable a culture of, you know, making it easy for the service user to just be out. So often, you know, service users will need to correct a provider and say, no, well, actually, I'm gay, or whatever it is. So the issue with this is that from a health or mental health perspective, you're actually expecting the vulnerable person to do the work. Many people might not have the confidence to correct a normative assumption, such as, you know, myself as a lesbian woman being asked, how long have you and your boyfriend been together? This impacts on internalized homophobia, transphobia, biphobia, feelings of abnormality, and also that the possibility that you could lose a client altogether. So someone may just put down the phone, for example, when they're calling up to make an appointment with a therapist. Thirdly, and this is something that's become more apparent, I think, as PACE has also had more of a focus on this, is that many services lack an intersectional lens in their approach. So this leads to false assumptions being made about people's identities. They struggle to understand, for example, that a trans woman might also be bisexual, or a lesbian woman might be a Muslim. This impacts the service that the clients receive to the extent that they're treated as monolithic and one-dimensional in their identities. And people may feel a pressure to sort of justify that, yes, I am gay and I am also black, and those two things can exist together.
Thank you, Jess. That's really helpful. Thank you. So what we now are going to do is have a video presentation. We asked two specialists the same questions that we've just been discussing. And we want to start with a presentation by Professor Elizabeth Peel from Worcester University, who's one of the academics who worked with us on our research study, and see what she has to say about the question. So let's watch.
So if we're thinking about why it's relevant to improve LGBT people's experiences in organisations, I think one of the key things is to work past the assumption that everybody who's engaging with services is assumed to be heterosexual. The heterosexual presumption or heteronormativity as it's known, is something that's very pervasive within organisations. And that presents a real challenge for LGBT people who are seeking to access services because they're assumed not to be there, and that's an added barrier. This can be reflected in the kinds of language that service providers and counsellors and therapists and other helping professionals use. So if, for example, somebody says to a client or a service user, oh, your partner, he, if that client is presenting as a woman, then that makes an assumption that's gendered, which then puts an LGBT person in quite a challenging position because they then have to counter that assumption, which can be difficult for people and doesn't set their engagement with services up on the right note. The other issue is that very often LGBT people can have poor experiences with services. And the research evidence through the RARE study findings and through numerous other studies has highlighted that when accessing psychological support or encounters with the NHS in terms of health service provision or social care provision, those poor experiences can potentially mean that LGBT people don't get the services that they deserve, they don't get the support that they deserve, and that can be very challenging for people. If we think of a very recent and current example that's been in the media, the case of the TV presenter Sue Perkins, who was told that she was infertile. Now, when she came out to the healthcare professional that delivered that news, when she said, oh, I'm a lesbian, the response was, oh, well, that's fine then, having children isn't going to be an issue for you, which of course is very problematic, and she's spoken quite publicly about how that particular experience was a very negative one for her. So being very mindful that service users can be from a range of sexual identities and present their gender in different ways. They could be gender queer, they could be trans, and not making assumptions about the people that are entering services that they will be heterosexual or they will be normatively gendered in terms of the gender that they were assigned to at birth, can make a very big difference for LGBT people.
So that was a very helpful contribution from Professor Elizabeth Peel. Sonna, I thought I could turn to you now, if that's okay. So you're PACE's counselling manager. Could you perhaps give us a sense of the sorts of issues which clients who come to PACE for counselling might bring into the therapeutic context, particularly because they're coming to PACE as an LGBT organisation?
Certainly, Margaret. What PACE offers and any LGBT organisation should be offering is exactly a safe and non-judgmental environment. It's taking away these assumptions to heteronormativity that we've been talking about and we heard Professor Peel talking about. It's about offering to the service user a space that it's not going to be for them to educate us about what they're bringing. It's about their knowing that we have the knowledge, we have the understanding of the issues they're going to bring to us. Now, obviously, we all, in general, we may present with the same, a wide range of issues. And obviously, LGBT people will come with anxiety and depression, eating disorders that we will see also in general population. But we also know there is a higher rate of prevalence of these issues in the LGBT community. But there are very specific issues that our clients come to us. And if you think about young people, we think about issues of bullying at school. We think about sexual identity in the time they are very confused about who they are and just discovering their sexuality and what does that mean. Thinking about coming out to family, coming out to friends. What does that entail for them? How is that going to change their social life? How is that going to change their support network? If you think about gay men, they'll come an increasing issue, for instance, of chemsex, which is because we're seeing more and more people coming through that, and HIV. And in terms of relationships, when we have one partner that is positive and another partner that is negative, how is that negotiated? Self-harm, that's also another increasing issue that we see coming through the LGBT community. Age, time that decided to come out, we more and more increasingly see older LGBT people coming out, and when they have already established families, and how is that negotiated with children and decide to come out as a gay or lesbian? What happens there? Race, culture, religion, how do you reconcile yourself with your beliefs and with who you are? How does your family reconcile with that? So issues of shame and guilt also come through, issues of rejection by family, issues of rejection by church. I mean, I could go on and on about that, but these are some of the issues that we see coming through the place.
Thanks, Sona, that's really helpful. Gemma, was there anything you wanted to add about the sort of clients and service users that you work with? What sort of issues they bring?
Yeah, sure. So, sort of reflecting on conversations and feedback I've had from service users, you feel the need, well, especially in the first instance, they don't feel the need to go into their lives as an LGBTQ person. That's not why they've come to us as such. Although it makes them comfortable, what it is stripping away that first level of anxiety. So they're coming to me, with advocacy. It's a very practical service with issues around housing and benefits, things like that. And the anxiety of having to come out with background on the relationship is not prevalent here. So they feel they can speak quite freely and honestly about the issues with somebody who is sort of similar to them, has is LGBT as well, and has empathy for their situation. Many have come felt judged, I think, by mainstream services when divulging any history that runs alongside the issues that are actually at hand. The clients, I think they feel, as I said, take away that anxiety so they can really hear what the needs are and deal with those.
Okay, thank you. That's great. So we now move on to the second question that we would like to consider in this webinar. And the next question is, where do organisations fail to meet the needs of LGBT people? We're going to start by listening to Professor Peel. There's another contribution from Professor Peel about this, and then I'll open up the discussion to our panellists.
So, where do organisations fail to meet the needs of LGBT people? Well, I'm not going to quote specific statistics or studies, but generally it's this assumption that can be pervasive in some organisations, certainly not all, and there has been lots of change in recent years in the UK and elsewhere. But part of the problem can be the assumption that there are no specific needs for LGBT people accessing services. So essentially this very liberal idea that everyone's the same. Now, on some levels, of course, that's true. People do share core characteristics and they are the same. But there are specific health needs and specific mental health needs that lesbian, gay, bisexual and trans groups of people may have that are not that are peculiar to those groups and do require some special training, some special skills and some knowledge that enables those issues to be dealt with sensitively.
want to avoid highlighting or paying too much attention to the individual needs of minority groups in order to avoid tokenism. Organisations need, though, to understand that achieving a high quality of service is achieved in part by valuing and celebrating diversity, rather than just sort of treating everybody the same. It does imply that LGBT people might have their specific needs and vulnerabilities ignored or not met because the service is just anxious to treat them the same as heterosexual or cisgender clients. So what we understand by this now is that a sort of one-size-fits-all doesn't actually work for all service users, and that we may actually miss some really key risks and vulnerabilities of particular minority groups by doing that.
Thanks, Jess. Sola, I was wondering if perhaps there was anything you might like to add about perhaps the training needs of counsellors and therapists?
I think, for me, organizations need to be aware of their limitations and what they can and cannot offer, and to be open to seek specialized advice and help and support, and really kind of focus on education and research, maybe in thinking how things have changed and how can we actually continue to update ourselves and mold ourselves to the needs of our service users. And if you're thinking about counselors and therapists, then definitely it is about training, it is about education. It's not about thinking one mold fits all, because it doesn't. And that will apply not just to LGBT, but any other individual that we know that we all have very specific needs. So it is about just understanding the limitations, and then what can we do about it, and where can we find more, and who can help us with that.
Thank you. So we now move on to the third question that we want to consider, which is how are mental health care seeking behaviours and recovery processes for clients affected by this reality? And by this reality, I mean the reality that heteronormativity exists. So what is the impact on clients and service users? And Gemma, I thought I could turn to you for this one. Is that okay?
Yeah, sure, of course. So I find that an issue that commonly arises for my clients is that health professionals can assume that the client's mental health problem is because they are LGBT+, rather than the issues that arise, so the real issues, or at least that's how they're feeling by health professionals. So, for instance, I'll give you an example. I've worked with a client who stopped engaging with his mental health team because they constantly refer to his sexual orientation as being the denominating factor of their depression and anxiety. Obviously, my client's issues were actually from the fear of him coming out, that he's going to be rejected by his family and his community, and was going to be made homeless because of his sexual orientation. He felt obviously really unheard, completely misunderstood by the professionals that were supposed to be supporting him, and couldn't see a way forward, and so therefore stopped engaging with him.
Thank you. Sonia, was there anything you wanted to add to this?
Yes, I think it's important to acknowledge that there is still stigma around LGBT people, and there is an active discrimination where LGBT+ people are excluded and are discriminated. And if you think about one of the findings, one of the examples that Nuno gave of Isabel, and how an assumption was made, and how that made Isabel felt, and also about the example from Gemma, from the trans patient at the hospital, where they actually didn't know what to do with him and where to put him. So this active discrimination will lead to not really focusing on a patient, but focusing on the disease, without really knowing what's going on, and making that the sexuality is the disease and not exactly actually what the patient brought. That would lead the specialist not to actually refer this patient to where they need to go, to the appropriate services. And not focusing on the recovery also, because again, we are still focusing on the wrong issue. And this active discrimination will lead to some kind of self-stigma from the patient themselves and self-discrimination, and the patient regarding himself as not good enough, him or herself not good enough to be looked at and to look at as an individual, and to the issue that actually brought them to it. If you're thinking about someone that goes to adopt a GP for physical needs, and then this happens to them, they'll come out without their physical needs being met, and again, with the added emotional need into it.
Thank you. We're now going to move on to a third video contribution from Sam Rankin. Sam is Intersectional Equalities Coordinator for the Equality Network and is also a bisexual activist. Sam's based in Edinburgh. She co-authored a research project about the experiences of bisexual people accessing services in the UK, which was called Complicated. It's available for download from the Equality Network. Let's hear what Sam has to say, and then we'll move on to some further
Why is it
questions.
relevant to improve bisexual people's experiences in organisations?
Well, it's very important that no matter how large or small a minority group is, that services take into account that specific people need specific needs. We're not all exactly the same. However, it's becoming more and more important to recognise the needs of bisexual people as more and more people are coming out as bisexual and more people are identifying as neither 100% straight or 100% gay. So recently YouGov did a survey where they found that up to 50% of young people in particular do not describe themselves as 100% gay or 100% straight. So it's very important for services to recognise that the prejudices against gay people are not the same as the prejudices against bisexual people. For example, in our recent research called Complicated Bisexual People's Experiences of Accessing Services, one person talked about how a nurse refused to treat her, and her mother overheard him saying to a senior nurse, she's just a greedy bitch, she should decide who she loves, men or women, she shouldn't love both. So through that example, you can see that that person wouldn't have a problem treating somebody who identified as gay, but had a specific problem with treating somebody who is bisexual. So biphobia is not the same as homophobia, and neither are the same as transphobia. So people really need to understand the differences so they can better tackle these kinds of prejudices.
Where do organisations fail to meet the needs of bisexual people?
Organisations fail to meet the needs of bisexual people in a number of different ways. Firstly, organisations are often unaware of how they raise bisexual identities by doing things like talking about gay and straight people when talking about sexual orientations, and not acknowledging that there are bisexual people and people who describe their sexual orientations in other ways. People often look at stats about LGBT people and then claim that X percentage of gay people experience whatever, when they're not taking into account that the LGBT or LGBTI faces a wide range of different people. Services can be very unaware of the impact on bisexual people of doing things like saying no matter if you are gay or straight or whatever, and being very dismissive, by not challenging biphobic remarks, like for example, saying bisexual people are greedy or freaks. Those kinds of low-level harassment really need to be stamped out. By not including bisexuality in their codes of conduct or other documents when they're talking about sexual orientation, just talking about gay people, or just talking about homophobia instead of talking about homophobia, biphobia and transphobia.
How are mental health care-seeking behaviours and recovery processes affected by this reality?
Well, in our research Complicated, we had an example of somebody talking about going to a psychologist, and the psychologist saying that it was their fault that they were raped because they are bisexual. So that example really shocked me, but what was more shocking was that when I went and consulted with bisexual people about the results out of the report, so many people said to me, oh yes, that is really common, or oh yes, that happened to a friend of mine, or even yes, that happened to me as well. So there is a lot of recognition within the bisexual community that you are going to experience bad things when you access services. In our report, 35% of respondents said that they experienced sexual harassment while accessing services directly related to their sexual orientation. And 61% of our respondents said that they experienced multiple discrimination. So when bisexual people are going to access services, they're expecting a lot of harassment, discrimination, and even sexual harassment. So we are less likely to come out, we're less likely to be honest about the totality of our lives and our histories, and we feel more anxious about going to access services, not only because of our bisexual identities, but also because of other aspects of our identities that we feel are going to be misunderstood. So I think bisexual people on the whole, no matter what research it is, it always shows that bisexual people have poorer mental health than lesbian or gay people, poorer health outcomes, higher drug and alcohol abuse rates. So across the board, we have poorer health outcomes, including mental health outcomes, and I think that that ties in a lot to how reluctant we are to go and access services, or to access services fully and honestly, because of the very bad experiences that we have.
So Nuno, there were some very relevant points raised by Sam there about the experiences of bi people and the very specific challenges that they face. There was also, I think, quite a bit in the RARE study, wasn't there, about, in terms of findings about bi people's experiences. Could you perhaps talk to us a bit about what you found?
Mm-hmm. Yes, absolutely. I mean, for the RARE research report I mentioned earlier, we only looked into broader comparisons between heterosexual people and LGBT identified people as a whole at that point, and between cisgender people and transgender people for other analysis. So we're now just starting to look into a little bit more into detail of what specific subgroups experiences are in regards to mental health. And so these are our preliminary findings I'm going to share with you. It's not published, but we're working towards getting it actually published sometime soon. So of the few analyses we've been able to run at this point, we found actually that when we compare gay and lesbian identified participants from the survey that we carried out that I mentioned earlier, so we're talking about approximately 1,000 participants altogether in this subset, gay and lesbian identified people, with those identifying as bisexual, and we're talking about 350 participants from the survey, so quite considerable numbers. We found that the bisexual identified participants were a lot more likely to consider professional counselors, therapists, or psychiatrists they have seen in the past to be more rejecting of LGBT people. This is also true when we ask them about their experiences of accessing groups that support people with alcohol or drug addiction issues. So again, bisexual people tend to consider their experiences in the past with accessing the services as being less welcoming, less accepting of LGBT people in general. We also have another interesting finding that links with this, which is that, again, when compared to lesbian and gay identified participants, the bisexual participants are less likely to have sought help of a therapist because of their sexual orientation. And I can share with you the figures associated with this specific finding. So whereas gay and lesbian participants, 22.5% of our lesbian and gay identified participants have sought help because of their sexual orientation, only 13.7 participants who identify as bisexual did the same thing. So we are coming across some significant findings between bisexual identified participants and also the lesbian and gay identified participants that shows or suggests clearly that this gap that Sam so well and clearly talked about does as a pattern here that comes across different segments and different experiences of accessing services, specifically for bisexual people.
Thank you, Lynn. So we're at the stage now where we have some questions from viewers that I can perhaps throw open to the panel to answer, and make any comments that you'd like to make at this stage about anything that you think perhaps we haven't covered that would be useful to cover. So one of the questions that we have from viewers is, what will be the benefits to my organisation of being more LGBT friendly? I wonder if anybody would like to start on that.
Well, I suppose a few things, a few specific benefits. If it's well communicated, one of the things that you'll see is more LGBT people as clients or service users. Research has also shown that LGBT people are attracted to employers that are outwardly LGBT friendly in their policies, for example, anti-discrimination policies or partner benefits, whatever it may be. So there's also a business case there for attracting the best talent from an HR perspective. Lastly, it's also just the right thing to do. So that's my answer to that. Okay, thank you.
Thanks, Jess. And I wanted to pick up actually on something that you said, Nina, about the findings about why people's experiences of seeking help from counsellors around their sexuality. I wondered sort of if you would mind perhaps picking up on that and talking about why that might be, why it might be harder for people to perhaps talk about their sexuality with counsellors, or why there might be less evidence that they're able to do that.
Well, in my experience, bisexual people actually experience homophobia from gay and lesbian and also heterosexuals. So they kind of get it from both sides or all the sides, and it makes it more difficult to kind of position yourself as an identity and say, actually, this is who I am, and I want to talk about it. If actually I'm from what is perceived to be my social identity, my group, then I'm also not accepted. So where can I come out? To whom can I come out? So that makes it even more difficult for someone to just say, I am bisexual. Because socially, as we see and as we heard today, it is not acceptable still to be bisexual. It's almost like you don't know what you want, you don't know what you are, or you really. And that has a serious emotional impact on the individual, and therefore it's difficult enough to go for help, it's difficult enough to go to counseling, it's difficult enough to admit there is something that I don't understand about myself. And if you don't have enough support for all the social network, then that just makes it almost impossible for bisexual people to feel comfortable enough to seek help.
Okay, thank you. I have another question as we speak. How can we provide LGBT services when funding is dwindling? That's an issue, isn't it, for the LGBT sector? Just now there's so much competition for funding. It's probably not an easy one to answer, but does anybody have anything that they'd like to say about that question?
I actually didn't give it a try.
Yeah.
I guess for me it is, how can we not provide services, period? Why make it specific in the sense of funding? This is a group of people, such as any other group of people, that needs help. Why does it make it less that we need to really think about, okay, LGBT needs, it's more difficult to get funding for that. For me, that's, I don't know if it's a political view or not, but it's about who needs help. All of us needs help, emotional help, and health-wise help. So it is about that for me.
I would also maybe try and comment briefly. I mean, speaking of my department, so to speak, I think research is very important, because what research has been showing us consistently is, regardless of all the progress we've been having around LGBT issues, inclusivity, and even improved mental health indicators over the last few years. However, still showing a difference between people who identify as LGBT and people who identify as heterosexual or cisgender. So I think research is an important resource to make a case, an important case, for the need of continuing funding for LGBT-specific services, or at least to provide a better training and conditions for mainstream services to be able to then provide the right support for people who need them.
Thank you. Because I guess our experience as an organisation is that some clients want specifically LGBT services. Yeah. Some clients would also like to access mainstream services but need to know that they're LGBT friendly, which is what your work is about.
Well, that's right, and I think the ultimate goal then for those clients is to have the choice. So it's not like, you know, we provide training with the ultimate goal to work ourselves out of a service, being in the LGBT kind of sector, and to strengthen mainstream services to the extent that we're no longer needed as LGBT specific counselling, for example. But what we want to do is obviously give service users the choice to access great sensitive mainstream services or great sensitive specific LGBT services, and then it's sort of up to them. I think the other thing, just very briefly to mention on how can LGBT services survive, collaboration. Collaboration covers a lot of, how many times can I say it? Both within LGBT organisations working together, but also working slightly outside the box, and perhaps you know, working with social health services or BME organisations or whatever it is. I think that is the way to survive right now.
And again, our experience at pace of working with mainstream counselling providers, like Relate, for example, is that there's a benefit to both of us.
Oh, absolutely.
Being able to do that. So we have about 7 minutes left, probably. And I do have another question which takes us back again to talking about organisations. So this question is, do homophobia, biphobia, transphobia and heteronormativity stem from individuals within organisations, or are they broader problems that affect entire organisations? Who'd like to have a go at that one? I guess there's something about those broader problems that affect society. So is it about the individuals within organisations, or is it about systems and organisations as a whole?
I think you've got a Foucauldian a thesis right there. I think it's very complicated, and I certainly think obviously homophobia, biphobia, transphobia are obviously views that individuals within certain organisations can put forward. Heteronormativity though and gender normativity are just a status quo. That's just, we do live, that's right, and I don't think there really is an argument to suggest that we don't live in a heteronormative or gender normative society. We just do. There are things that organisations can put in place to minimise sort of break heteronormativity and gender normativity when it comes up, thinking specifically within a clinical context, you know, asking, say, in a counselling room, do you have a partner, what is their name, rather than, you know, how long have you and your husband spent together, or whatever it is. And obviously, homophobia, biphobia and transphobia can be tackled through, say, whistleblowing, anti-discrimination policies, equality and diversity policies. But these are huge, broad, systemic issues from a normativity point of view that I don't think are quite so easy to touch, and therefore quite so easy to change.
Because they're not just issues, there's a language involved, and there's cultural and social implications and in them. So yes, I'm with Jess, it's too big to, I think, discuss in 5 minutes. And actually have an answer to that, a clear answer that, is it organization, is it individual? For me, actually, it's both. And it's actually more general than that, but it is from both.
Anyone else would like to add? Okay. Well, I think we're coming towards the end of the webinar, so I would like to thank our panellists, Nuno Nodin, Sona Barbosa, Jess McIntyre and Gemma Muniz for joining us for this interesting discussion. I hope that you found it interesting, viewers, and that you will continue to tweet to us and get in touch with us about what you've enjoyed. And also, I'd like to thank Professor Elizabeth Peel and Sam Rankin for their video contributions. And I'd like to thank Groupon for making it possible for us to have this webinar today. We don't have these sorts of facilities in place, so it's been great that we've been able to use them in this fantastic location overlooking the river by London Bridge. It's very splendid, so thank you for that. We've enjoyed it very much. Do remember to register for the second webinar that we'll be holding on the 3rd of November, which is about how to improve the experience of LGBT people in your organisation. It will be broadcast live again on the 3rd of November, which is in 2 weeks' time, from 2 to 3 o'clock, and you can find the link to register on the PACE website. In the meantime, please do join us in the conversation on Twitter using hashtag PACEWebinar, and send us your questions, comments, observations to our email, which is info@pacehealth.org.uk. Selected questions will be answered by the panellists during the second webinar. And make sure to check PACE's website for more information resources, which is pacehealth.org.uk. For those of you interested in the rare research, as Nuno has said, you can obtain the full research report. You can download it from the website, so please look out for it. And thank you for watching. So until next time, bye-bye.
Thank you.
Bye.
Bye.